Good morning, everyone. Welcome to this webinar this morning. I'm Dana Corson, Manager of Media Relations at the National Academies of Sciences, Engineering, and Medicine. Thank you for joining us for this webinar on the report that was just released, titled Framework for Equitable Allocation of COVID-19 Vaccine. You can now download a copy of the report and other supporting materials at www.nap.edu/vaccine allocation. For those of you not familiar with the U.S. National Academies of Sciences, Engineering, and Medicine, we are private nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. For each requested study, panel members are chosen for their expertise and experience and serve pro bono to carry out the study's statement of task. The reports that result from the study represent the consensus view of the committee and must undergo external peer review before they are released, as did this report. I have with me several members of the committee to discuss the report, but before I introduce them, I just want to go over a few reminders. Please note that this webinar is scheduled to last 1 hour. We'll start off with a presentation summarizing the report by the committee co-chairs, and then we'll open it up to any questions you may have. Simply click the Q&A button at the bottom of your screen and submit a question. Also, the slides from today's webinar and a recording of the webinar will be available after the event. So now I'd like to introduce the members of the committee who are here with us today. We have Dr. William Fagey, committee co-chair and Emeritus Distinguished Professor of International Health at Emory University and former CDC Director. Next, Dr. Helene Gale, committee co-chair and president and CEO of the Chicago Community Trust. And next we have James Childress, university professor emeritus at the Institute for Practical Ethics and Public Life at University of Virginia. And next we have Abigail Echo Hawk, citizen of the Pawnee Nation, Director of the Urban Indian Health Institute and Chief Research Officer at the Seattle Indian Health Board. Next, we have Jewel Mullen, Associate Dean for Health Equity and Associate Professor of Population Health and Internal Medicine at the University of Texas at Austin Dell Medical School. And last but not least, we have Saad Omer, Director of the Yale Institute for Global Health. And with that, I'll turn it over to National Academy of Medicine President Victor Zhao to give brief remarks to get us started. Dr. Zhao?
Thank you and good morning and welcome to this important report release event for the Committee on Equitable Allocation Vaccine for the Novel Coronavirus. You all know there's been an intensive effort to accelerate the development of safe and effective vaccines to protect people from COVID infection. But even under the best circumstances, experts have speculated that we may have an effective vaccine by the end of the year or early next year. Despite these promising efforts, we all know that doses will be limited, certainly initially at the beginning, and there won't be enough for everyone. In this context, a scarce vaccine or vaccines will be needed to be allocated in ways that are thoughtful, strategic, and fair so as to reduce morbidity and mortality and virus transmission, to protect the public's health and socioeconomic well-being. Therefore, it is important that we have a well-thought-out framework that will help determine who should get the vaccine first, who next, based on science, public health, social factors, and equity. Any vaccine allocation scheme must explicitly address the high burden of COVID-19 experienced by specific populations, given their exposure and compounding health inequities. Importantly, the framework has to be developed independent of political and other undue influences and is trusted by the public. I believe that is why NIH and CDC came to us, the national academies, outside of the government, to assemble a top team of experts to provide independent recommendations for an overarching framework. As you know, National Academy is known to be a trusted, independent, evidence-based advisor. Accordingly, we convene a committee of experts with the highest integrity to take on this important work. I want to take this opportunity to thank the committee co-chairs, Dr. William Fagey and Dr. Helene Gale, and all the members of the committee who have dedicated their time and expertise, spent at least 3 months, the last 3 months, putting in long hours to this important task. I also want to thank the staff, particularly Andy Pope, Rosemarie Martinez, Lisa Brown, and Benjamin Khan for their tremendous effort. So the committee had to consider the following. What criteria should be used in setting priorities for the equitable allocation vaccine? How should these criteria be applied in determining the first tier of the recipients? And as more vaccine become available, what population should be added successively to a priority list of recipients? And how would this framework apply in a whole different set of scenarios, different characteristics of vaccine, and different available doses? So the overarching framework is to maximize societal benefit by reducing morbidity and mortality caused by transmission of this novel coronavirus. So very shortly, you hear the committee's recommendation. So let me just summarize by saying, we all know that, and I don't have to tell you, that public trust is absolutely critical to success of any vaccine administration campaign. This is why we also built a robust public health engagement strategy, including a public comment period on our discussion draft. This is back about a month ago, in which we received over 1,400 written comments. We hosted a 5-hour public listening session attended by nearly 2,500 people, and committee heard compelling oral comments, which were rich and important, that resulted in the improvement of the final report. I know that it will be important to continue engagement of the stakeholders after the report is out and the complex work of allocation and distribution of vaccine begins. Therefore, we're planning to engage the public, medical community, and others in order to promote trust and engagement and to facilitate understanding of the principles for equitable allocation at the federal, state, tribal, local, and territorial levels. We also stand ready to provide ongoing advice and assistance to CDC and other agencies as they move forward on this very important issue. So without further ado, let me turn it over to committee co-chairs, Bill Fagey and Helene Gale, to tell you about the report, and they will moderate the whole session going forward. Thank you very much indeed.
Thank you, Victor, for that opening. And next slide, Ben. Victor mentioned that CDC and the NIH asked for this review by a non-government organization. And this turns out to be so important for the trust factor that people know that this is an independent group that is looking at this. And it was mentioned that this National Academies actually established by Abraham Lincoln. So it's an old traditional place to go for getting recommendations for the government. Next slide, please. The committee turned out to be a very unusual group of people, 18 people from different backgrounds, different experiences, and over a period of only 2 months and 1 week from the first time that we met until we had a report, they were able to go through all of the problems and come to agreement. So there is no minority report. This is an agreement of the 18 people. We were faced with such uncertainties at the beginning, and we asked ourselves, how close could we get to certain recommendations in this sea of uncertainty? We've done the best we can. We will continue to have uncertainties, and I want to emphasize that even when phase 3 trials are complete, None of the trials included children under the age of 18, so we have to wait for the Advisory Committee on Immunization Practices and others to decide what is done with that age group. When the studies are complete, we still won't know how protective is the vaccine in people of my age in their 80s. And so it's going to take time to work out some of these uncertainties. Next slide, please. Victor mentioned the overall arching framework for advising on how to allocate vaccine when it becomes available. It'll probably start with small amounts, and then I would guess, since there are so many vaccines that are completing phase 3, that there will be a time when suddenly we will have lots of vaccine and can meet the demand. But the first months are going to be very difficult. Next slide. And so we were asked to look at how would we prioritize, who would we put first in line, and a list of other charges ending up with, at the bottom of this, you can see, how do we deal with the vaccine hesitancy? Because it's clear that the groups of people who might be the best served by the vaccine will be the groups that have the most hesitancy. Next slide, please. The approach was we had 8 virtual meetings, and these were long virtual meetings, usually on Friday afternoon and early Friday evening. But Victor mentioned we had a public meeting where we released 3 of the chapters in draft form. And this whole process has been so rushed, people had only 24 hours to study our draft, but then they came on, hundreds of them, with requests for 5 minutes apiece to advise us on what we should do. And then even after the 5-hour public session, they had days to provide us with comments and remarks and recommendations. And as Victor mentioned, over 1,400 people. This is the interesting part. The public was truly involved in this. We had a chance to see what they thought of what we were doing early on and then change some of our recommendations based on what the public suggested. Next slide, please. So these were the 3 chapters. Chapter 2 on lessons learned, 3 on the framework for allocation, and 4 on the framework for applying the allocation. Next slide, please. Some of the background. Everybody knows from the news how deadly this has been for minorities. Minorities have higher rates of disease, they have higher rates of death, and people would have expected that we could come out with a recommendation saying, vaccinate minorities first. We didn't do that because we decided to look at race versus racism. And I'm so pleased that we did it that way because we said it's racism that is the root cause of this problem. Because people have personal vulnerabilities and social vulnerabilities. This virus has no concept of color, but it has a very good concept of vulnerabilities. And so the personal vulnerabilities, CDC has listed some of these. It's a long list, but the ones at the top of the list turn out to be heart failure, kidney failure, obesity. On the social vulnerability, they turn out to be things like overcrowding living conditions, multiple generations in one home, people going to work because they have to, they can't work from home, and subjecting themselves to risks at work, poverty, the unemployment, children home from school, many problems. And so we took the approach of what are the risk factors involved in both social and personal vulnerability, and let's address those and say it will be an attack on racism, not on race. Next slide, please. The number of vaccines in production is just unbelievable. Around the world, 149 vaccines, but we have 3 or 4 vaccines now quite far along in phase 3 trials. And phase 3 trials means that people are satisfied with the safety of the vaccine, They're satisfied that the vaccine can actually produce some indication of immunity. And now phase 3 is asking, but can the vaccine protect people against the disease? And so you have large studies with half of the study group getting the vaccine, half getting a placebo, and then waiting to see what are the attack rates in the two different groups. So some of these studies are very far along, and they're different kinds of vaccines. And this is the interesting thing. Some of the vaccines will require 2 doses of vaccine in order to give immunity. One of the vaccines will require only 1 dose. One vaccine can be refrigerated, and that's sufficient. 2 of the vaccines have to be refrigerated at minus 80 degrees centigrade. So you can see the logistic challenges in trying to keep this vaccine cold at minus 80 degrees. Now that's over 100 degrees Fahrenheit, minus 100 degrees Fahrenheit. You can see what the challenges will be. But if you think that's a challenge, think in terms of what if a vaccine comes along, the third one to come along, which turns out to be better than the other 2? What do? Do we start over with the people that have already had 1 dose of one of the previous vaccines? So the problems and the uncertainties continue to abound. Next slide, please. We came up with a framework, and with the framework, we looked first at the foundation principles. And I am so pleased because with most committees that I've been on that are similar to this, we start out with the science. And then we work backwards to ask, but what are the ethical principles we should be applying? What are the equity principles we should be applying? This group started from the beginning by looking at ethics and equity, and having discussed that, then went to the science. We worked for a long time on what is our real goal. And it's easy to say, well, the goal should be reduce deaths, reduce mortality. It's easy to say, no, the real goal should be to reduce transmission. It's easy to say the real goal should be to open this country back up, to stop the social problems that are resulting from it. We said it is a synthesis of all of these problems, and that our goal should take that into account. So we're looking at mortality and morbidity and transmission and the social disruption and asking how can we best attack all of that. We came up with some allocation criteria. What's the risk of actually getting the infection? And if people get the infection, what's their risk of having severe disease, requiring hospitalization, perhaps even dying? What's the risk of them passing this on? And this is an important point, that as we compare these risks, it's not that some people are more important than other people. It's that some positions may be more important than other positions. A position where if you lose that person, downstream there are people who will not get medical care or help. That becomes a higher priority for vaccine than someone like myself who can stay home, work from home, does not have to get out and take the risks. Then with all of these criteria, we looked at what are the mitigating factors. Who could actually use a mitigating factor to reduce their risk, such as I mentioned for myself, staying home and not actually getting into a situation where I'm exposed. We follow this with the allocation of phases. And I'm going to, at this point, turn it over to Dr. Helene Gale to talk about the phases and then the recommendations that we make. Dr. Gale.
Thank you very much. We can go to the next slide. And this slide just looks at some of the committee's foundational principles and how they compare with some of the other frameworks that are either developed or in the process of being developed. And I think it gave us good comfort to see that our foundational principles really very much synced with the other frameworks that were being developed. So on to the phases, and I think the overarching framework that Dr. Faggy described, I think led us to thinking about this in terms of phases. And again, oftentimes vaccine allocation frameworks talk about different tiers. And we decided not to use the notion of tiers, which is more hierarchical, but really phases, because this is really around how do we phase this in given the availability of vaccine, with the understanding that when vaccine is scaled up, we hope that everybody who is eligible will be able to take a vaccine. So this is a phase-wise approach. And we looked at the phases based on the risk criteria that were described before about risk of acquiring or transmitting the infection, risk of serious disease or death, and risk of negative impact on society. And if you go from phase 1 to phase 4, it really looks at how different populations stack up against that risk criteria. So for instance, in phase 1, we have these two phases. The first, phase 1A, is a jumpstart phase, really looking at the high-risk health workers as well as first responders who are both at risk for acquiring the infection, and also, as was described before, have a hugely important role to play in terms of keeping our health system available for people in the midst of this pandemic. And also potentially, if a very scarce supply of vaccine, this would be a small enough group to be able to get that vaccine first and allow time for developing the systems for larger allocation and distribution. The rest of this phase, the phase B, looks at some of the other parts of our risk schema, looking at people of all ages who have the most severe underlying comorbidities, or the ones that put people at the most significant risk of severe illness or death. And then again, looking at older adults who live in congregate or overcrowded settings, who have both the risk of acquiring or transmitting the infection, as well as the likelihood of getting serious disease. As we know, the largest number of deaths have occurred in people in older age adults. The second phase, again, looks at, if we look at it from the standpoint of our risk criteria, we look at people who are in situations, teachers and critical workers who are in high risk settings, who have a high likelihood of getting transmitted. We look at people with all ages who have comorbidities that put them at moderate risk of illness and death. And then people in congregate settings like homeless shelters, prisons, jails, et cetera, who both have high risk because of the nature of the settings of acquiring and also of transmitting. And then we have older adults who, again, all the evidence demonstrates have a higher risk of severe consequences if infected. The third phase, young adults, children, and people working in industries not in either the previous two phases. And then the fourth phase is anyone residing in the United States who did not have access in the previous phases. So again, just to point out, this really correlates very well with how we were looking at the risk, as well as issues around who might be able to mitigate some of those risks. Importantly, because of our focus around equity and because of the impact that we know this pandemic has had on communities of color, particularly, and other communities who have social vulnerabilities, we said across all of these phases, the CDC social vulnerability scale should be used, which would locate the geographies that had the highest risk populations and the most social vulnerability. So we would say that using this framework of these four phases, priority should be given to the geographic areas that would be identified by this social vulnerability scale that looks at poverty, minority status, household crowding, transportation, access to health services, et cetera, with this important focus of equity. Now I'm going to go through the recommendations, and I'm not going to go through them in a lot of detail. We really hope people will have the opportunity to read the reports, and particularly the recommendations. There's a lot in there, but at a high level, I want to just go over our 7 recommendations. The first one is that we want this framework to be adopted. We were asked by the CDC and NIH department agencies of the Department of Health and Human Services to develop this. And so we really hope that HHS, along with the state, tribal, local, and territorial health authorities, will adopt this allocation framework and set out in the committees that were set out in the committee's report, and develop a national and local guidelines. And we really want to put the stress on the fact that we feel like it is so important that a national framework be laid so that there is coordination of this, and that it coordinates with the local, territorial, state, and tribal authorities, which is the way national public health exist in this country. And this is an important aspect of our recommendations. Second, we looked at issues related to coordination and cost considerations. We don't want cost to be a barrier, and we also felt that this issue of coordination at all levels was critical. So we have two recommendations. The recommendation number 2, leverage and expand the use of existing systems, structures, and partnerships across all levels of government, and provide the necessary resources to assure equitable allocation, distribution, and administration. We really want advise that HHS should commit to leveraging and expanding the use of these existing systems, the existing networks, and make sure that the coordination across the national, local, state, territorial, and tribal levels is really adhered to, so that there is a system in place that makes this equitable distribution possible. The second recommendation from these considerations is that we felt strongly that the vaccine should be provided as well as administered without any out-of-pocket costs for those being vaccinated. We asked that HHS should coordinate across agencies so that the COVID-19 vaccine is available at no cost, that providers are assured that they will have the ability to submit for reimbursement, and that public health mass vaccination campaigns are federally supported and funded to provide these vaccines at no cost. And we really feel so strongly about this point, because after all of the resources that have been put into making a vaccine and manufacturing a vaccine, we want to make sure that cost is not a barrier to anybody getting this vaccine in the face of this incredible public health crisis. The next set of considerations look at the communication and community engagement considerations. And I think, again, in the discussions that Dr. Fahey mentioned, we felt it was so important that the issues around making sure that people actually have use, and there's uptake of the vaccination. And so we have the recommendation focused on this to create and appropriately fund a COVID-19 vaccine risk communication and community engagement program. HHS should create and appropriately fund this risk communication and community engagement to support the health authorities to have an integrated approach. And again, I think a lot of our focus has been on making sure that there's a national strategy, but it's well integrated, and the importance of both the communication aspects as well as community engagement. We know that there has been a lot of vaccine hesitancy, and we'll talk about that on the next one, but we really know that to overcome this, having a strong communication campaign and having strong engagement with communities, trusted partners, is going to be a huge part of making sure that people actually access the vaccine. I mentioned the issue of vaccine acceptance. Vaccine acceptance. We have two recommendations around vaccine acceptance, because this issue is, as people know, and several have, the two previous speakers have talked about, that we know that there is a huge amount of skepticism because of the speed of the development of the vaccine, because of some of the confusing statements that have been made, we really want to make sure that people are very clear, understand the science, and that we can do everything to minimize the kind of hesitancy that we know exists in the American public, and particularly among groups who might have the most to benefit from vaccines. So our fifth recommendation is to develop and launch a COVID-19 vaccine promotion campaign. This should be a nationally branded, multidimensional vaccine promotion campaign using what we know, rigorous evidence-based health communication, social marketing, and behavioral science techniques, so that this is truly a well-resourced but also well-constructed vaccine promotion campaign. And the next recommendation, again, following on the concerns about acceptability, is that there really needs to be an evidence base for effective strategies for the vaccine promotion and acceptance, and that we rapidly start building an evidence base for these effective strategies, so that we're learning as we go along, making sure that what we do as we develop this campaign is based on the best knowledge and science that we collect as we go along, and that we make sure that we're understanding the complex needs of diverse communities. And finally, global considerations. We know this is a global pandemic. We know that this is an issue that doesn't just affect us, and that as in any global pandemic, global collaboration is so critical. The United States has always played such an important part of any global public health effort. And so we made a recommendation to support those issues, that we should support equitable allocation of a COVID-19 vaccine globally. We want the US government to commit to a leadership role in demonstrating equity, not just here in our own country, but also looking at the equitable allocation globally. We recommended that the US government opts into the COVAX facility at Gavi. This is a facility that globally people are coming together and coordinating vaccine availability and distribution. That we should deploy a portion. We suggest, as an example, 10%, but that some proportion, some meaningful proportion of the US vaccine supply should be made available for global allocation, and that we engage with and support the World Health Organization and its member states because of the important role that the World Health Organization plays, not just in this, but in any pandemic, and really believing that it's important that we be part of that global collaboration and support the World Health Organization. So with that, that's a quick run through of the recommendations and our framework. And I'll just turn it back to Dr. Fagey and this is a summary of our recommendations. I'll turn it back to Dr. Fagey for some concluding remarks, and then I will kick off the Q&A.
Thank you, Helene. I would like to just give some personal reactions to what I've been thinking about over the last 2 months. One of them has to do with philosophy. And I told a story yesterday as we debriefed CDC and NIH, but I didn't tell the whole story. The story is that some years ago, I was talking to the state health officers, and during the question period, one of them asked, could you tell me what is the philosophy behind public health, and how does that differ from the philosophy of medicine? And I told him that my understanding was that the philosophy of science is to break down the walls of ignorance, to try to find truth. And that's what NIH is trying to do all the time. I said the philosophy behind medicine is to use that truth for every individual patient. But the philosophy behind public health is to use that truth for everyone. And so the real philosophy behind public health becomes social justice. When I finished, a man jumped up, Dr. Cannon, the health officer for Rhode Island, and he said, I've been in public health for 50 years and I've never heard that. But he said, I know intuitively it's true. Don't ever give a talk again without saying that. Other people shouldn't have to wait 50 years to understand the philosophy behind public health. So now I've said it. And what happened over the last 2 months is that the committee and the staff tried to use the very best science available as a tool for social justice. The second thing, and Ben, I think you can turn off the slides if you want. The second thing was the challenges of uncertainty. Everything so uncertain. When the vaccines would come out, what they would be like, how protective they would be, and this uncertainty will continue. The point is that vaccines, even if they're effective, do not replace what we're doing now, which is masks and distancing, washing hands and so forth. It's just one more tool. To make that point, what if we had a vaccine that was 70% effective? That's great. But it would mean that 30% of people getting the vaccine would not be protected, but would not know that. And so they have to continue using masks and distancing, washing hands, and so forth, unless we have a big program looking at antibodies after vaccine. And I don't think that's likely to happen right away. So uncertainties will continue. I am absolutely so pleased by the way we took on racism head on. I think this will change what public health does, not just for coronavirus, but how public health looks at the problems of the social vulnerabilities of people. I like the idea that we said build on what we already have. We have an immunization program in this country that started in 1955 when Senator Lister Hill passed a bill that said the government would buy polio vaccine for all children in this country. That was the beginning of the vaccine program. It's continued to improve. By 1993, it had improved so much that we were having very low levels of childhood vaccine preventable diseases. Jonas Salk and Robert McNamara went to the Rockefeller Foundation and said, it's so impressive what vaccine has done in this country. How can we enlarge this to a global view? And it started a program that ultimately led to the development of Gavi, the Global Alliance for Vaccines and Immunization. Gavi has now turned out to be the single biggest program with experience in delivering vaccines in the world. And it all started because Bill and Melinda Gates put up $750 million for 5 years to start this organization outside of the global programs such as WHO and UNICEF. And it turned out to be the glue that held these programs together, became so good. I was worried after 4 years, since no one else was contributing, that Bill and Melinda Gates might get tired of this and actually withdraw. Instead, they gave another $750 million for Gavi. And the next day, the UK put up over $1 billion, Norway put up $250 million, and that started the whole program. So we have a real domestic investment in Gavi, which has now become the world leader in delivering vaccines. So the report says build on what we already have. I'm so pleased with the fact that these recommendations are national recommendations, but with state and local flexibility. And that's the way it should be. It's the beginning of a national plan to address COVID-19, but with plenty of flexibility at state and local levels. And I'm particularly pleased with what Helene was saying about the report saying this is a global pandemic. We provided leadership in the past. It's not only that the world needs continued leadership from us, it's that we need the information coming from the rest of the world. We need to watch to how is this virus changing? Are we still going to be able to use a vaccine on it? Is it mutating to the point that we have to develop new vaccines? We need the rest of the world to be part of this program. And so I would end with my pleasure at seeing how this group of people in 2 months' time came up with a national plan that really makes a difference. This is the biggest public health challenge we've ever faced in our lifetime. Everyone has to be part of it. And I appreciate how the national academies stepped up, provided great staffing, and how this committee did great work. And I thank all of you for listening. Helene?
I think we'll turn it over to Lisa and Dana.
Yes, thank you for that presentation. So we've got a lot of questions that have come through. I will start with I'll start with this first question. If ACIP has decided to hold off on recommending an allocation framework until after a vaccine is approved by the FDA, should states use your framework to start planning now?
Yeah, I think, we understand that ACIP will continue to develop recommendations, but we hope that our framework is something that people can use as a guideline to get started of thinking about the different phases as well as what needs to happen in terms of implementation. So our hope is that this is a way of giving states, territories, and tribal authorities a place to start and a framework that can be useful, that will be further refined when ACIP recommendations come out.
And I think the Advisory Committee on Immunization Practices has been doing so much work on this. It will take them no time at all to come up with their recommendations once they see the vaccine is on the brink of being released.
Thank you. Next question. In appealing to negative societal impact, do you distinguish between narrow and broad social utility? The former indicates a short-term benefit during a health emergency, and the latter is broader social worth. Please clarify.
Jim, I don't know if you want to weigh in on that.
To try. When we think about roles that are so important for continued societal functioning, for meeting healthcare needs and the like, we're thinking there about people's narrow roles. We're not thinking about their overall social worth. We are reminding ourselves at every point that each person has equal value, dignity, and worth, but that in some settings it's necessary, in order to protect society, to pay attention to those roles and to make sure that we protect people in those roles so that all people, including a variety of vulnerable people, can be protected as well. So that distinction is very, very important. We're concentrating here on very narrow social roles that are important for society's functioning, including the provision of healthcare.
Thank you, Dr. Childress. Next question. Did this committee address ethical issues around how U.S. allocation impacts global justice and distribution? Did the committee examine how the U.S. is one of the very few countries in the world which is not involved in COVAX and its efforts for making vaccine available in poorer countries?
Yeah, well, I think our last recommendation on global considerations, I think, covered that. I think we feel very strongly that we should be part of the overall global effort. That we should, and we recommended that the U.S. actually participate in COVAX. We recognize that this is a global pandemic, and we can't just think about how we protect U.S. citizens and think that we won't be impacted by what goes on with the rest of the world. So we felt very strongly that it was important that we be part of it, and we also felt that that we hope that our framework, and particularly this framework of equity, was something that went beyond our borders, and we thought about how to be equitable from a global standpoint as well. So I think the points that the question made are very much covered in our last recommendation. And I don't know, Bill, if you have anything to add.
And I think the conclusion of the committee was so strong that we even recommended that we should be sharing our vaccine right from the beginning. Some share of our vaccine, we said maybe 10%, but it could be some other figure, should be shared with the rest of the world immediately and given to this group that is working under Gavi.
Thank you for that. Next question. If geographic region is to be used as a cross-cutting consideration using a vulnerability index, would this be further stratified by sending early vaccine to geographic areas with high rates of disease transmission? For example, states experiencing rising caseloads.
Jewel, do you want to answer that?
As we've talked about the kinds of flexibility that the framework allows for, it puts in the hands and thinking of local and state officials exactly how and where they might need to do that. And to do so in a more precise and specific way, given that the social vulnerability index gives the chance to hone in a little bit more from region into neighborhoods, census tracts. So certainly that would be possible. And what we would also continue to hope for is that within that, the framework and all the equitable principles are applied.
And I might add two things on that, that part of the report says some of the vaccine could be held back by CDC in order to address hotspots or areas of high social vulnerability. I think the same thing is true of American Indians and Alaska Natives, that if you were to provide vaccine for a village in Alaska, for instance, it would not make sense to go to the effort of getting vaccine to that village and then doing a small part of the high priority people. You would vaccinate everybody that requires vaccination in that village. Abigail, do you want to say anything about how this might work?
Yeah, so I really, the committee was really cognizant to ensure that we used and appreciated the language of tribal sovereignty within the report to ensure we respected that government-to-government relationship that existed between tribal communities and the federal government. And then as we think about the example that Bill just provided, really, understanding that when you go into a village, for example, is very geographically isolated, that you've already brought in all the resources to do the vaccination of, say, that small group. You should use those resources at that one time to do the entire village to do the most good. So really looking at the societal impact.
Thank you very much. Next question is, can you speak about how you would define worker populations according to the phases/risk levels? Who determines which workers fit into which phase? Are you using the CISA list to determine this or other lists? What criteria are being used to assign risk level?
Yes, Saad, do you want to take that?
So yeah, so it's a nuanced approach. So one approach is to start with the DHS essential worker list, but we didn't sort of restrict ourselves to that, and we recognized the fact that even within those groups, beyond the functions, there is this ability to work remotely, etc. And so there's this concept of teleworkability that some folks have worked on recently. And so when we explicate this recommendation for the way we define that is critical workers in high-risk settings, we take that framework and sort of amalgamate that and provide guidance to categorize these workers based on not just their function, but also their ability to telework, etc., and some of those nuances.
Thank you, Dr. Omer. Next question. Did the committee include the fact that there could be multiple types of vaccine being given to patients at the same time or rolling out at different times over the course of a year?
This is one of the uncertainties, and it's really the Advisory Committee on Immunization Practices that will have to make those determinations. What do you do if you have different vaccines actually competing with each other at some point? And if we know something about protective effect of one vaccine versus another, it's not a role that our committee could deal with, but it's a role that the Advisory Committee on Immunization Practices will have to deal with.
And I think from the standpoint of our report, well, we looked at a variety of different scenarios, including, having, multiple vaccines. And I think what we did see is that there really wasn't a need to change the actual framework or the phases, but how those are, how different vaccines might be used, would be determined by ACIP and other groups. But the phases as such, we felt still made sense regardless.
Thank you. Next question. Will there be any discussions on how and when to include persons with disabilities within distribution plans?
Oh, Jewel, you wanted to say something about that?
No, go ahead.
Yeah, well, I smiled because I'm so happy for the question, because it also gives us a chance to I'll make a point about people who are differently abled, similar to what we said about distinguishing race from racism. We didn't necessarily take the category of disabled and then say there's a phase that people with this designation would fall into. So if you look at phases 1 and 2, for example, there are people who have disabilities that would be among the groups in congregate settings, for example, who might also be those who are eligible or considered to be among that phase 1 group. But then if you go to phase 2 and look, you'll also see articulated clearly people with disabilities there. And that's to me, one of the beauties of this, is that we're not assigning people to a category and then saying they therefore belong in a phase.
Thank you very much. Next question is, it appears to me that the only people left in phase 4 are people aged 30 to 64 in low-risk jobs. Am I interpreting that correctly?
Go ahead, Saad.
Yes, so that's one way of looking at it, but there's a reason why there is a specific phase 4 that it does that certain groups and profession groups, age groups, and other profession and occupation-based groups come into that categories that are not covered elsewhere. But it also establishes, if you will, the right for every resident in the U.S. to say that unless it is not medically contraindicated, they should get that vaccine in a finite amount of time. And that's what's going to open up the society in a more sustainable manner. There's another purpose this kind of approach serves is because there are inequities, for example, in identifying comorbidities. And yes, there is a lot of focus on how to do that in an equitable fashion in the rest of the report. But those who are we not able to identify their risk factor because of inequities in data. In fact, so one of the biggest inequities in this pandemic are inequity of data. And so then they capture in a more, in that last phase. And then it gives flexibility to the programs to say that when they get to that stage, they can have a more streamlined, a somewhat more easy to implement program where they just capture everyone else who's not vaccinated.
There's another point I think to consider here, that hesitancy is not forever. And there will be many people in the first groups who may be hesitant and will not get vaccine, but over time will get confidence in the program and they'll end up in phase 4. So there has to be a phase 4 to take care of those people.
Thank you. We have time for 1 or 2 more questions. Will family/household members who would individually be assigned to different phases be allocated to the phase of the highest risk person in the household?
Yes. because we recognize that people living in the same household, and oftentimes the people who are at greatest risk are people who are living in households where social distancing may not be possible, we want to give consideration to whole families as part of this framework.
And it's simply a matter of efficiency also. If you don't have to go back twice to the same people, as we were talking about with Native Alaskans, that if you don't have to go back to the same place twice, it's just a matter of efficiency.
Thank you. What is the role of nursing education and nursing practice in this massive vaccine allocation process?
I think, first of all, we recognize that health professionals are going to be an important part of this process. And as we talked about communication efforts and ways in which we can get people fully accepting the vaccine, fully aware of it, understanding what their risks are, et cetera, we know that health professionals are going to be an important part of that. Nurses clearly play a huge role in health education and are an important part of the system that we will rely on. So, while we didn't have a specific recommendation around nurse education, clearly nurses play such an important role. They're important providers of education, and making sure that we do include health professions in our overall national education and communication campaign will be very important.
Thank you, Dr. Gale. We are now at 11 Eastern, so I think that's all the time that we have for questions. I'd like to thank all of our speakers for joining us today. Thank you all for participating, and I know Dr. Gale wanted to close us out this morning.
Yeah, I just would like to close us out simply by saying thank you. First of all, thank you to everybody who came and listened. We hope that this was a briefing that was informative. As has been noted, we think that this is an incredibly important effort and hopefully will start helping to frame a national response to this pandemic. But I also wanted to specifically thank our committee. As Dr. Faggy started out, it was an incredible committee that came together in unbelievable ways to create this under real time pressure. So thanks to all of our committee members, as well as to my co-chair, but particularly wanted to thank the National Academy and Victor, your leadership. Wanted to thank Rose and Andy, your guidance, your supervision, your leadership. But we really wanted to especially recognize and thank the study team, Lisa Brown and Benjamin Kahn. Your work, your diligence, your around-the-clock commitment to this, your guidance, your help in helping us to refine this and make this the excellent product that it is. We just wanted to make sure that we expressed our appreciation to both of you, particularly for the incredible job that you've done in getting us to this point. So thank you all.